Hello and welcome to the part of our Hormone Summit that so many women have been seeking and wanting and asking me, will there be somebody on to talk about breast cancer and hormones? So I am, Julie, so honored to introduce Dr. Julie Taguchi. She's board certified in hematology and oncology. You've been in this decade for several decades, I know, in primarily or predominantly in the field of breast cancer. And you're also married and you have two children. So you're really a full woman. So thank you so much for coming on to share your wisdom with us.
Thank you very much. I appreciate it. I'm honored to be here and thank you for the invitation.
Well, this is such a hot topic now. You know, so many women tell me, I'm so afraid that I might get breast cancer, or my sister has it, or my friend has it. And, how many women actually get breast cancer? How do we look at that in terms of the incidence and when they're going to get it? How common is it for women?
So currently, the way the statistics run, I'll say the average risk of having breast cancer through a woman's lifetime, that's through age 80, is currently 1 in 8, probably getting closer to 1 in 7 soon. And that's over a lifetime. The average age of breast cancer is about 62. But the highest incidence when breast cancer is diagnosed is between age 45 and 50. So of course, Dr. Hall, what happens between age 45 and 50? We're losing our hormones. It's menopause. We're losing our hormones. Everything is starting to fall apart. We have more autoimmune disorders. We have all these other things. And so that's the highest incidence is just right before around age 50, 45 to 50.
Yeah.
So and that perimenopausal.
Is that in women who are on hormones and off of hormones, just the peak incidence in all women, basically?
That's just the general statistics for the incidence of breast cancer for all women.
So it's really helpful to talk about some of the root causes, the core root causes of breast cancer, because, this has been pinned on estradiol, on estrogen. It's dangerous. It causes breast cancer. But how do you view breast cancer in terms of its causes and why we get it? And, we're going to talk about prevention in a bit. But what do you think about, why do we get it now so much?
Why do we get it now? Okay, well, first of all, I don't know everything. Medicine doesn't know everything, but I'm sure there are multiple causes of breast cancer. And of course, I think we could certainly start out with the genetics, right? There's hereditary genetics, excuse me, familial genetics, where people, pass down genes like the BRCA genes. And now we're getting familiar with other gene mutations, such as the ATM mutation and the CHEK2, PALB2 gene families, that those people have higher risk for breast cancer. And nobody knew that. That's kind of genes that we're looking for now, and we're finding them in families. So that's one. And genetics really, they really account for about 15%. I've seen 10%, but as we get more information, is about probably closer to 15 to 20% of the breast cancers. Well, and the number one risk for breast cancer, really, this is what I say, it's birthdays. The number of birthdays, the older you get.
Yeah, oh my God, my birthday's coming up.
Yeah, the more birthdays you have, the higher risk of breast cancer. So there's this aging thing that happens. So we can't help that, right? So that's the number one cause of breast cancer is age. The other reasons that we can get breast cancer are reproductive, and I know you know this. So women who have their firstborn pregnancy really before the age of 28, and you breastfeed for at least a year, we know that is a risk reduction. Those are risk reduction. If you breastfeed, that's a risk reduction. If you don't breastfeed, it's a risk increase of breast cancer. If you don't breastfeed that baby you had. So there are reproductive factors, and I think that this is super important, because if you have your first baby after 30, your risk of breast cancer goes up. If you don't have a baby, you have a higher risk of breast cancer. But if you have your first baby after age 40, it's the highest reproductive risk factor, and it's a 4-fold risk. Okay, so I don't think women know that.
Well, I think that, the levels of estrogen, for example, in breast cancer are so elevated, 10,000, 11,000, whereas a normal woman's estrogen levels are maybe 150, maybe 200, maybe 100. So, I mean, it's just like such a strange kind of increase in hormones in general. And progesterone is very, very high too. So, and we're inflamed, we're tired, and we're stressed, and, all these other things too. So
But yes, I was gonna say, just to address that higher estrogen level, there's a paper that I read, and it gave great insight. It used PCOS, or polycystic ovary syndrome, as a perfect scenario. And of course, that's more common now, right? PCOS.
yeah.
But it gives a scenario where you have the higher androgens, the insulin resistance, high estrogens. There's basically no progesterone cycling, right? And within this particular paper, it alluded to the fact that when the estrogen receptor is not functioning well, you have estrogen resistance, then the body compensates in trying to fix itself and repair itself by raising the body's own estradiol as a fixer against estrogen resistance.
Yeah.
So it makes a lot of sense to me from what I've been doing in my own research.
I love that. We don't, as gynecologists, we really don't know the cause of PCOS. I mean, it used to be felt that it was primarily related to sugar and to elevated sugars and elevated testosterone. Now we're talking about maybe the gut is the cause, but we don't really understand that, which is so interesting because it's very common. But what about some other risk factors or other things that you look at, like vitamin D, hormone D3, or some of those causes?
I do. And, just PCOS is also an increased risk factor for breast cancer.
Right.
So it is. Yeah. One of the things I like, I'm a big fan of vitamin D. I think, certainly there's more and more data coming out. I think one this last month, maybe, about how better levels of vitamin D are associated with cancer prevention. So we're not necessarily treatment, but definitely prevention. And so, as everybody knows, vitamin D is not a vitamin. It's a hormone that has incredible functions. And it is under the influence of estradiol as well. So when estrogen's not there, it doesn't maybe do its job as well, but again, it goes with immune function, immune regulation, obviously involved with gut absorption, calcium, etc. I'm a big fan of iodine too, because iodine is really important for thyroid health. The most important reservoir for iodine is the thyroid, the second is the ovary, and the third is the breast. And if you don't have enough iodine or enough thyroid hormone, you can't breastfeed, nor can you ovulate or get pregnant. So there's a huge connection there. And it's even possible that might even be one nutritional deficiency that might be a cofactor into breast cancer manifestation. And again, I think cancer is like the perfect, when cancer happens, it has to be the perfect storm. It's not, I don't think it's just one thing, right? It has to be a perfect storm. So
complex disease. It's a complex disease. It's no longer like, one bacteria causes one disease. I mean, it's like heart disease and dementia and all these things that we're really learning more about. What about inflammation and high sugar levels?
of course.
I think that's a core cause of cancer in general, or breast cancer?
Absolutely. Because we're looking at inflammation being like the root cause for many things, not only cancer, but of course, heart disease and dementia, et cetera. So the inflammation is a big deal. Again, it might be we're back to gut, because, I know you know this, but when you have your hormones they're metabolized in a certain way. They go into the biliary system or your gut, and they get, recirculated. So that enterohepatic circulation is important for hormones. You have to have a good gut to process hormones. Yeah. I remember having a patient who was on topical or transdermal hormones, and she called me And she said, I am like sweating like a pig and I can't sleep. I'm irritable. I feel like I have no hormones. I need more hormones. I said, I can't believe that your labs are fine. The last time you were fine, the last time I saw you. What's going on? She goes, well, I'm having a bowel obstruction. I said, oh, okay. Yeah, I hope you're taking care of that, right?
God.
So, and I'm waiting it out. She's waiting her bowel obstruction out. I tested her level. She had an estradiol level of 2,000.
What?
Okay. Yeah. Because her gut wasn't moving and it wasn't functioning. And it taught me something that's really important. That gut has to be in good health and it has to move. So she was having, when those levels get that high, they block and shut themselves off. Estradiol and testosterone, right, have their own regulatory system, right, with the SHBG. So you can't get too high or too low because it will shut itself off.
Right. Absolutely.
Too much estrogen is like having no estrogen.
Oh yeah. So I totally agree with you. You know, that when women have very high levels, then those levels fall and they can have terrible mood swings and night sweats. And it's kind of like falling off a 3rd-story building rather than falling off, 5 feet. I mean, the swings are terrible. You know, I remember after the birth of, I think, my 2nd child, just having massive sweats, probably as my, estradiol level was falling from extremely high levels down to almost nothing. Women after the birth of a baby, their estrogens are very, very low. And they experience menopausal symptoms during that fall. Not just at the low level when we finally settle into a low level, but during that decline. And it causes a lot of postpartum depression. It's associated with that. So, I mean, let's jump in a little bit because that's very helpful. Knowing some of these core root causes. I mean, then we're gonna talk later about what we can do. Do you feel like, just to finish that up, do you feel that alcohol is a problem? You know, I know that some people say, if you drink more than a drink or two, it's a 10% increase. But is that bearing out with your knowledge or not really?
Well, with the literature, in the literature, it is consistent that at least alcohol before your first pregnancy tends to have an increased risk of cancer, associated with cancer at least. And there's more data showing that if you're a binge drinker and before pregnancy, that's associated with a higher risk of breast cancer. So the alcohol, I think there's something there. But the risk factor is still between 1 and 2 fold average risk.
Yeah.
Okay.
Because
it's women, not higher than.
Yeah, women so often say, well, I come back from a hard day and I'll have a glass of, champagne or a little glass of white wine, and then I relax. And so I've always sort of thought, well, stress is a big cause of any type of disease. And surely stress, that's the adrenal gland. So that's hormonally mediated. So, I mean, what would you say about stress as a, maybe not related to alcohol, but stress as a cause of breast cancer or just cancer in general?
Well, let me finish up the alcohol question because I get that question all the time. Can I have alcohol? And the studies are showing some differences from zero alcohol is the best to maybe it's okay to have your 4 to 5 ounces of alcohol, have a glass of wine a day. So that's kind of bearing out as being okay. Higher alcohol for women, that's where it's showing higher risk for breast cancer. So, I think, I advise women, if you can stay within that 4 or 5 ounce of alcohol, then I think that's reasonable. Okay. So that's what I tell my patients. But there are some papers that say any alcohol is bad, and it's not many. So it's usually moderate is okay, or that 4 to 5 ounces a day is okay. And therefore, that addresses the potential stress reduction.
Right.
That is really important to have. Of course, there's many other ways to have stress reduction other than alcohol. But I think stress is a factor when it comes to cancer. I think stress is a factor when it comes to inflammation. So I do think that stress maybe in the indirect route is a cause for cancer.
Right. Julia, I see, Dr. Taguchi, I see so many people, so many women who come in with very depleted adrenals. So the adrenals are an endocrine gland. They sit on top of the kidneys and they modulate your stress. And they also have a big impact with immunity. We're all concerned about immunity now. And is our immune system working? Is that important for cancer prevention, our immunity? Or not?
Number one, I think, absolutely. Those T lymphocytes, T regulatory lymphocytes are really important. They're our surveillance system, right? We apparently make cancer all the time. And we have an immune system that's able to recognize that and take it out when it's nothing. And so we don't get a cancer that's landed and starts to blossom where it starts. So yes, that's really important. Of course, the immune system is affected when you are under chronic stress and inflamed. It doesn't work as well. So you bet.
There you go. So it's inflammation, possibly high sugar. Do you think that high hemoglobin A1Cs and high chronic sugar damage in the body is associated with increased cancer or breast cancer, or not that much?
I would say that we know that diabetes is associated with a higher risk of breast cancer, as it is endometrial cancer and even some GI cancers. So, and that goes also to insulin resistance. And that's kind of the same PCOS thing. We have insulin resistance. So I think that setting of insulin resistance is a potential for cancer development.
Right. Yeah. So we have inflammation, high sugars, we have stress, we have perhaps, low D3, vitamin D, perhaps low iodine.
Not sleeping. We have to sleep.
Not sleeping. Stress.
Not sleeping.
Yeah, not sleeping. That's when we detoxify our body. So that's so helpful. So I understand that when you sit with somebody who's had a breast cancer, that you talk about all those underlying etiologies or causes and help them to correct them.
I try. Absolutely.
Yeah.
And of course, don't forget nutrition. Nutrition is obviously a big one.
Gluten. Now, gluten is a source of inflammation for a lot of people, and so is dairy for a lot of people. Is maybe a lack of greens. Are you talking like that in terms of diet, like the cancer diet, or how do you view that in terms of diet, or is it more in terms of sugar, or?
You know what? It depends on the person. I can't give you give a blanket diet to people. I have to look at what they're doing, what they're taking, how they're eating, when they're eating, and then we have a nutritional program here anyway. But sometimes I recommend, sorry, you need to do the keto diet for reasons that I come to when I talk to them, or or you should try the gluten-free diet based on some of the things I see and examine. Oh, you have skin rashes and blah blah blah. I mean, it depends on the person.
Yeah.
So
I totally agree with you. I want you to know I absolutely think that each woman or each person has an individualized need and what they're intolerant to, which can cause inflammation. It's absolutely unique. So I appreciate that answer. Okay, so we have all of these root core causes of breast cancer, but you know what? Estrogen is always blamed. Gynecologists are really frightened to prescribe estrogen, and we don't seem to be that frightened to prescribe the birth control pill, but it's been so vilified, Dr. Taguchi. I mean, why is estrogen vilified in terms of hormone replacement or, some of the other reasons we use it?
I wish I knew the answer to that. I don't really understand it. But I could surmise that maybe people don't want to take the potential risk factor of cancer that's been, that estradiol has been given. It's been given a bad rap for years. I think estradiol actually over the last several years has been accepted as maybe not causing breast cancer more so. And now it's the progesterone, of course, right? I think that's the other target right now. Mm-hmm. So I just don't think people may not want to spend the time or take a risk of an old soundbite, estrogen causing breast cancer. Since you touched on the word birth control, I really have to say something about this, because that's one of the things I get concerned about and I have women who ask me about their daughters, what do you do about birth controls? People are so shocked when I tell them, you understand that a birth control pill causes controlled menopause, right? The hormone levels are, boom, they're down. Okay, it's enough not to have a hot flash, but they're down, and we're not cycling, we're not having the normal patterns, and of course we have associated osteoporosis,
Ugh.
depression. I mean, I could go on and on and on, and guess what? After more than 5 years of the pill is associated with breast cancer. Higher than 10 years, much more. But certainly, I have patients I see at age 50. They're still on the birth control pill. They've been on the birth control pills for 30 years. They sort of forgot to get married and get pregnant, because what does the birth control pill do? It can reduce that drive, the hormonal drive, that maternal drive to get married, have kids. You can still have sex, right? But
Maybe
it's
not
very, very,
maybe not that great a sex.
so, and not get pregnant. So anyway, the birth control pill is another potential risk factor for, and then it leads to maybe not having children. Like I said, it's very interesting.
Yeah. So listen, this is music to my ears because early on in practice, I've now been in practice for 3 decades, and I went to USC, and my residency was in gynecology and obstetrics. And coming out of practice, I prescribed the pill probably to thousands of women in the first, I would say, 4 or 5 years. And then I started to see that women were getting they'd come into me, young girls, 18, 20. I'm depressed. I'm losing my hair. I feel that, my brain isn't as sharp. I used to be such a good student. I don't really feel sexual. Maybe I'm gay. I mean, they really, really didn't feel like themselves. And it was then that I started measuring these levels of women on the birth control pill. And you're absolutely right. They have menopausal hormones because, basically the birth control pill suppresses the pituitary gland and hypothalamus, and the estrogen, the ovary goes to sleep. So I'm just amazed that you know that, and really, really appreciative that you know that. I mean, you're one of the few people who knows this, Dr. Taguchi. As gynecologists, we want to help women prevent pregnancy. Okay. So
I have to laugh because as the breast oncologist, I want them to get pregnant early.
Oh, this is striking terror into the hearts of many women who haven't had babies. But look,
it's not politically correct. Sorry.
No. It is politically correct to help women know what their dangers are. And I don't think that women should have a baby to prevent breast cancer. I think they should have a child because there's so many other ways, as you've mentioned, really very clearly as to how this plays into the propagation or of breast cancer. So, okay, let me just ask, is estrogen dangerous? Does estrogen cause breast cancer? Because, what are your thoughts on that? A woman's menopausal, she's coming in, she's crying, she's, Dr. Hall, I don't want to get breast cancer, but, can you help me? Well, what do we do? What do you think?
So in that particular instance, for that woman, she's symptomatic. I absolutely would consider hormone replacement and obviously estrogen as part of the hormone replacement. So do I think it's dangerous? We know that, I can tell you that in the research that I have done, estradiol does not cause breast cancer, or all women would have breast cancer. I do have to say that if you give estradiol alone for at least 10 years by itself without progesterone, then we start to see a rise in breast cancer, like in the women's, the nurses study and those kinds of things, those cohorts of observational studies. But by itself, no, it's very, very helpful. And if you're I'm hoping, and we don't have a lot of data on this, that if we give it in sequential, giving estradiol with sequential progesterone, that will reduce breast cancer if you're taking it for longer than the 10 years. I think women should be considered to have hormone replacement. Not all women need hormone replacement. I don't think physicians should be afraid of giving it. And of course, if you get hormone replacement, you could be treating not only depression, but osteoporosis or osteopenia, dementia. Estradiol keeps you insulin sensitive, by the way. Estradiol, if you don't have estrogen, you get insulin resistance. If you have it, you're more insulin sensitive. So we eliminate that factor. So there's a lot of great things for women who are postmenopausal. Helps you sleep. I could go, there's 4,000 things it can do, estradiol.
Yes, there is. It's
Oh,
like
and it helps with
other
your,
hormones.
right, and it helps with your gut. Your gut functions better on estradiol, and your hormones are metabolized through. I mean, I could go on. We don't have enough time.
Well, go on a bit if you want. I mean, but I couldn't believe that women were coming to me, around menopause saying that they had GERD and acid reflux and, terrible bloat. And I realized, oh my God, that's a symptom of menopause, of low estradiol, of low estrogen. And that was really a game changer for me, seeing how important, how, we're not isolated. All these hormones, all these enzymes, our lifestyle, it all works together. We're all, we're all connected.
Yeah, exactly.
Yeah.
Exactly.
So now we're going to move to a little more controversial topic. So women who have had breast cancer and who want to use estrogen. I mean, that is a no-no. I mean, you'll go to almost, these women will go to oncologists, because I always send them to oncologists to really have an opinion whether it would be okay to use some estradiol cream, and they're told absolutely not, categorically, that this is dangerous and that's the cause of breast cancer. So, I mean, you specialize in this. What is your opinion of that?
Well, okay, let me start by saying off the bat that vaginal estradiol or vaginal estrogen is considered to be fine. I think even through all of our thought leaders, our breast cancer thought leaders at this time, that's fine. So I think hopefully can just take that off the table. Any woman on tamoxifen can have hormones. That's another thing, because we give it to premenopausal women and for breast cancer blocking estrogen receptor. But for other women who come to me who've had a history of breast cancer and they want to take hormones, I started prescribing hormones for this particular reason, because I was having these women. We castrate women. Yeah, I hope you understand that. For breast cancer treatment, for an estrogen receptor positive tumor, we castrate women for 5 years. That is our standard. And when that happens, there are some women who can tolerate the treatment really well and they do fine. And then there's a subset that does not do well at all. And they're like, I'm seeing these women, they're going, what is the point of living if I have to be like this? I don't want to live. I don't want to get out of bed. And they're on their medications. They're on their psych drugs. We're trying to support them. And they're like, just, I'm done. And I want whatever it is, and I want my life back. And I would say, well, I know why this is happening. It's because you don't have estrogen. They go, I want my estrogen back. And then, of course, we have to have the conversation about the potential risks. So there are lots of women who are willing to take that risk of having hormones back, and in whatever risk of breast cancer that might happen as a relapse or a progression, in order for quality of life. That led me to do another, like a mini observational research study, which I haven't published, and it's been like 20, I know it's like 20 years. And I found out that women, the women who, this is even with what I'm going to call the Wiley protocol, which is a higher dosing. It's not a traditional anything, but it's basically a format of hormone replacement that tries to mimic the reproductive cycle. Mm-hmm. So there's a lot more hormone than most people are comfortable giving. But even in that group of women, they were the same, if not even a little bit better than what I could call statistical for that particular patient staging and their diagnosis. They did not do any worse than the average.
On estrogen. So this is a woman who's on estrogen and progesterone, not continuous progesterone, but fluctuating levels, and they did better. What about the Women's Health Initiative in terms of women who took, I mean, they were on Premarin, most of them. I mean, did that increase breast cancer a lot or not?
Absolutely. So we know that continuous combined progestin plus estrogens, or estrogens plus progestins, increase the risk of breast cancer. That's why the Women's Health Initiative was stopped in 2002, I think, or 2003. I don't remember. I can't remember exactly, but it was stopped because there was a slight increase, not a slight. They called it a 26% increase of breast cancer in that population. So But we know that. And and again, progestin is not progesterone. It's a drug with hormone effects. And it can sit in an androgen receptor. It can sit in the estrogen receptor. It's not progesterone. So, but it does stop the proliferation of the endometrium, which is what it was designed for.
Yeah. That has an absolutely deleterious effect on the breast. What about the women who are on estrogen only? How did they do in that study? I mean, it's an old study. It was, based on Premarin, which comes from the pregnant horse's urine. And, that was probably, I mean, thank goodness they were helping women with menopause, because women were getting electroshock therapy and being put in TB sanitariums. They were so crazy and sad. But that's all the way back in the 1940s that they really came up with Premarin. And how did women do on Premarin alone in terms of breast cancer?
So you bring up something really important, because remember you asked me the question about, gynecologists don't want to prescribe hormone replacement, or they tend to shy away from it. But what's so interesting is that in the Women's Health Initiative, they showed that taking Premarin, and mind you, that's, horse urine, which does metabolize a little bit into 17-beta estradiol. Taking Premarin daily for 6 years reduced the risk of breast cancer by 23%. So if women took this pill, this estrogen pill, for 6 years, they had a reduction in breast cancer. That risk reduction held for 10 years, and they reported that as part of the Women's Health Initiative in 2013, I think. So that is a breast cancer prevention therapy for women who don't have a uterus. What do you think of that?
Amazing. Really. So
nobody talks about it, though. Nobody talks about it.
So estrogen does have some prevention to the breast. What about people with positive estrogen and progesterone receptors in their breast cancer? What about that? Because women come to me and say, estrogen caused my breast cancer because my oncologist told me I have estrogen positive and progesterone positive receptors. What about that category of women? Do you think that estrogen is the cause, or is just, that's normal breast tissue? What's your thought?
Most likely is not the cause of the breast cancer. And I don't think estradiol by itself, I don't think estradiol, at least without in its pattern and with progesterone, causes breast cancer. But the people don't really understand that the normal breast cell has estrogen receptors, progesterone receptors, and androgen receptors. They're there on the normal breast cell. And I tell the patients that the breast cell gets hijacked by the cancer process. And we know that there is about 40% of the time, 45, that breast cell cancer can be driven, the growth can be driven by the influence of estrogen, but it's not the cause. But it can help foster growth for, again, we're talking a fraction, like 40-45%, not 100%. The most important thing then goes back to, well, that other 60% or 55 or 60%, what is driving the growth of that cell? And that's where I tell people, like, your insulin can do that. Insulin sits in an estrogen receptor, I believe. These other things that you need to focus on, your nutrition, your exercise, your inflammation, that is everything that you're in control of that you got to knock down.
Yeah.
And so I think women, given that premise, women who want hormones, I have to go over and educate their risk of relapse and understand what their risk of relapse is. And if on hormone replacement, what potential consequences or benefits they have from that, and if they're willing to take that. And most women do, because their quality of life is so bad, they would rather make the decision for quality of life.
And it's so interesting that you started the conversation by saying, so when is the peak incidence? Well, it's when women go into menopause, because there's so much stress. So I kind of, I don't know, I have this pin here. I kind of say, well, when estrogen is low, you have higher stress, you have, internal stress, you have higher sugar, you have higher cholesterol, you have higher inflammation. And if really, and not all people do this, of course, but it tends to be more associated with a loss of estrogen, these things. So if suddenly at that stage, all of these risk factors are rising, and those risk factors can cause certainly more diseases as we age, because Dr. Taguchi, we're talking about 40 or 50 years more of life.
Yes,
And,
yes.
you know, it's a lot of living that could have other diseases arise, when you remove the protection of estrogen. I mean, I don't want to put words in your mouth. So if that's not true in your oncological field, I'd love to hear if you feel that estrogen has some protective effects for women or not.
Yes, I have a lecture slide that basically says, women around 1900, women died around the age of 47. And so half of them were dead by the time, before they made it to menopause, right? And the other half lived past age 47 and, maybe died of other things. It wasn't that many women, so they didn't have a lot of experience with menopause. But now, if we're going to live, women are going to live to be 90 something years old, 100, 120, the people are even projecting. Do you want to live another 50 to 60 to 70 years without hormones?
Yeah.
And me, no. So you have to think about that. So I think that's another thing to think about, because we do know that, we talked about the stress, we know that the estrogen can help address the stress. Certainly works with anxiety, that can erase serotonin. We know that it helps with the brain. We know there's a lot of data in estradiol in the brain, a lot of it. And obviously the bone, everything we talk about, estrogen affects the entire body, right?
Mm-hmm.
So better living with hormones, maybe.
Yeah, well, I am, and I, really respect your opinion. So what about thyroid, and what about testosterone as causing breast cancer or helping to decrease it? What do you think about the other hormones?
Well, okay. When I think about hormones, pardon me?
DHEA, the adrenal hormones, something like that.
Well, I replace them physiologically when I do hormone management. I think they're very important. When I think of hormones, I think about, normal relationship to the other hormones, right? Too much testosterone for a long period of time is not, I don't think, good for you, a woman. Yeah. It can do the same thing, insulin resistance, and higher cholesterols, and it follows that pathway. Mm-hmm. So when I think about hormones, they're all important. I replace the ones that are low, and I go for physiological levels of hormones. That's how I practice. But I think they're all important. The ones that I know about. I'm sure there's hormones I don't know about that someday I'll be able to manage, and hopefully manage better.
Well, I do feel, and from my work with basically menopausal women, it's that the hormones all work together. That menopause is not just an isolated drop in estrogen and progesterone, but the adrenals get unsettled, the thyroid can be affected, the other hormones, the gut is off, and so we have more inflammation and more core root causes of diseases in general. So it's really a field that I'm proposing that certain gynecologists specialize in menopause and perimenopause. I mean, we have a level in gynecology, a subspecialty in gynecology where they treat infertility. Well, this is very, very important. But those doctors don't treat menopause. And yet menopause, like we said, is with us 50, 60, 40 years. And we need that in our field. So this is a plea to, if anyone is hearing this who's involved with creating subspecialties, we need that. And it needs to be collaborative with oncologists and cardiologists. So we need to become an expert in that field, because now, medicine is so separated that we don't dare encroach on another person's field. And
it's surprising to most people that gynecologists, and I'm sorry to bring in the endocrinologist.
Say it out. Just say what you need to say.
Just the general endocrinologists do not do hormone replacement.
No, they don't. There are a few specialized ones that do, and thank God they do. But yeah, you're right. Yeah.
But generally they don't. And people are surprised that they don't.
Yes. I feel like this information that you've given Dr. Taguchi is going to be really helpful in terms of women making an informed decision, because it's our life. It's our, it's our precious life, and
Yes.
our ability to be happy and loving and I mean, this is important too.
It is.
So
And I was just going to bring up one more thing and real quickly, because I have patients who like they carry the EPO4 gene for Alzheimer, and they have breast cancer, and I've talked to some of these people, and we talk about hormone replacement, trying to protect them, and I just think it's really important that we medicine needs to be more collaborative, because there are women who said, I want to take my hormones because I don't want to deal with the dementia. And then they've got doctors saying, you need to be on your aromatase inhibitor, or you're going to die from breast cancer. I go, well, your risk for breast cancer recurrence might be this, but your risk for Alzheimer's is like this. And, you can choose. They get a lot of discordant information. So again, gynecologists trying to help with hormone replacement, menopause therapy, if you want to call it, and endocrinologist, the same thing. I mean, it's helpful for our whole population overall.
yeah.
So thank you for the plea.
Well, that's really it's a broad view, and you've clearly just become such a role model, Dr. Taguchi. Women look up to. I mean, you're an innovator, you're a pioneer, you're going to places where other people are afraid to go. So how did you find it in yourself to become, first of all, an oncologist and then a pioneer in this field? I mean, I find it fascinating.
Well, thank you. I was going to say, some people, they have different opinions that I have to deal with, but that's okay. First of all, in terms of oncology, I will tell you, oncology called me. Okay, it's a calling. I started writing papers in high school about, I'm so interested that smoking caused lung cancer. I said, that's really amazing. And then I was in college, as unopposed estrogen caused endometrial cancer. I wrote a paper in that in the late 70s. And so I thought that was interesting. And so in medical school, I wanted to do everything in medical school, but I was the only one in my medical school class who could figure out there were 14 different lymphomas at the time. I could figure them out. I don't know, the only one. So, well, maybe not the only one, okay, fine. But it was easy for me. And so I was just called to that. And then in terms of breast cancer and hormones, I have to tell you, back at, I was introduced to, well, I shouldn't say this, somebody came stalking my hallway with a bunch of papers that said, progesterone can kill cancer cells. And I was like surprised. And so this was actually Susie Wiley at the time. She came in my hall and so there's a man, you're treating a 90-year-old doctor. And I'm giving him lots of progesterone, Dr. Taguchi, I want you to know. I said, okay, well, he can take whatever progesterone he wants because he's on hospice. He can write his own prescription. If that makes him happy, I'm happy. Good.
He's
He had
dying.
metastatic transitional cell carcinoma, lung mets, bloody urine. This was the third relapse he had had. He had moved out to California from New Orleans. And literally 6 months later, he was still alive. He didn't have any blood in his urine and his chest x-ray cleared up. And I said, what happened?
Oh my,
and that's what got me into the hormones.
oh my God.
I
That's
know.
fascinating. That is
Yep.
absolutely fascinating. So have you had to have a lot of strength and kind of courage to stay in this field and to speak some of the I don't know how to call it, but the emerging data, because medicine kind of, I mean, the way we practice medicine lags about 20, maybe 25 years behind the research. So you're kind of taking the research and bringing it more immediately into practice. And that takes a lot of courage, Dr. Taguchi.
Well, yeah, I was gonna say, I've kind of been going against the research for 2 years. I've been doing this for 20 years. For 20 years, treating women with breast cancer with hormones, and myself. It is. I have to tell you truthfully. Initially I tried to stay low, stay stealth. I don't want any, I didn't want any controversy. And I work in a multi-specialty group, which I love to pieces. but they know that I have this other thing happening here, and they've been very nice to me in terms of, you know, well, if someone's going to give hormones to an oncology patient, it better be an oncologist. So, you know, nobody else will. So they've been kind to me here.
Yeah. So I see, you know, I saw the Michelle Obama film, you know, I think it was on Netflix. And after seeing her, I just thought, you know, I can do that. I mean, not her, she's amazing, but I can have personal courage. I can speak out. I can really, you know, I don't have to be afraid. And I see you as embodying that. I mean, that's beautiful. You're a beautiful example for other women who have an avocation or a calling so they can really live their full life. And
oh, that's awesome. Thank you. Yes, I am not afraid. I am not afraid. So I feel very confident in what I've learned and the research that's there. You know, and the other thing when it comes to cancer, like I said, there's that aging thing. There's so many things that we don't know and we can't control. We can't control everything, but we can make decisions. And if we're making decisions for quality of life, we're making decisions for, you know, trying to make our best life or best health decisions, we should be able to do that.
we have
You know,
to.
and there are plenty of women. Yeah. Just to let you know too, I mean, in terms of, I've been doing this for a long time. I've had women who had high grade, node positive, estrogen receptor positive breast cancer that have been on hormones. This one woman, let's see, oh, she had bilateral disease. She had one breast cancer, had a second breast cancer while on the hormones. She had a second one. So that second one was already there. It's just that over time, hormones fostered its growth. We found it. It was small. But she lived and had multiple surgeries, back surgeries, in the same spot at L4-5. On her third surgery, the doctor called me and said, I think she's got cancer there. She had cancer in one area in her entire body. Guess where? L4-5. At L4-5, she had tumor in the surgical site. They've gone in 3 times, and that's where her cancer relapsed. So after, what, she 12, 13, 14 years on hormones. So you're back to the inflammation fostering the growth of the tumor that had probably been there, but suppressed all these years.
Yeah. Just
so there's so much we don't know.
Interesting.
We don't know.
Interesting. Well, listen, I'm very grateful. Any closing message that you would like to give women? Because you are one of the thought leaders for women in the world. So any closing message?
No pressure. Thank you, Dr. Hall. I think for women who they want to consider hormones, they should be able to consider hormones as something to look at for, particularly if they have symptoms. People will tell you that they shouldn't get hormone replacement therapy to prevent heart disease, but 1 in 2 women die from heart disease, and hormones can help that, or at least, you know, stave it off. So there's a lot out there that they should be able to if they want to do that, they should be able to do that. So don't be afraid of it. They shouldn't be afraid of estrogen causing breast cancer, because 1 in 8 women get breast cancer, but 1 in 2 women get heart disease. Hello?
Oh, hello. Oh my goodness.
So anyway, I think, and for women with breast cancer, you know, it is the current treatment is to say no to hormones, and that's because people are afraid and don't know. But you know, if you have a different philosophy and you really want a quality of life and you think they can help, or you can try, you know, that's your call to do that, to try.
Yeah, really, our life is in our hands, and we can consult experts, we can consult the literature, and ultimately, it's how we choose to live our life, and with really the highest ideals in mind. You know, the highest potential, the highest human potential. Thank you, Dr. Julie Taguchi.
I have one more.
Oh, good.
One more thing. When you have that conversation with your doctor, I think women have to absolve them of the risks, because doctors are afraid of risk, right? They don't want to hurt their patients. And so I think I've had more success having other women get hormone replacement when they tell their treating physician, I know you're telling me everything you can to your best interest for me. I have chosen X, I absolve you of all risks. I'm making the decision for me. So when that comes across, I think physicians are more likely to work with and cooperate with the patient. That was my final.
Well, that was a wonderful way to end this, and I'm really grateful for this talk. I mean, this is going to be seen by thousands and thousands of women, and I'm happy to partner with you. I'm happy that you're so close in Santa Barbara, and we'll be putting up your domain name and how to reach you, and I appreciate this, and all
Thank
women.
you so much. Thank you. It's been a pleasure. Very much. Good luck with everything, and you're awesome. By the way, we go back at you, sister, because you do something that's so unique, and a lot of people so appreciate what you do. So thank you for you being the leader out there as well. You're definitely a pioneer, and you know, pioneers get shot in their back, just so you know.
I've experienced a little bit of that.
Yeah. So just, yeah. So anyway, thank you for that, and thank you for being strong and staying, you know, staying up.
Thank you. Thank you. So from our heart really to the heart of all women. Thank you. Bye-bye.